care then and now. Next, On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Ever since the time of the traditional healing practices of Native Americans, medicine has evolved. Country docs using a buggy to get to the patient is turned into networks of clinics and hospitals and several levels of caregivers. The vast majority of the changes have helped, but some, unfortunately, have not. Tonight, we'll take a look at some from each side of that question. Okay, let's take a look at this week's Prairie Doc quiz question. Choose the best answer now. What are reasons to like the electronic medical record requirement? A, availability of records. B, enhances the patient's story. C, increases time with the patient. Call or email your answers now. We'll take quiz answers for only the next 10 minutes of our show. If you can have a question at the same time you call in your answer, we'd like that. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of A Picture of Health. This book was written by myself and accompanying photographs by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answers in. We answer your questions as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email. So I want those questions. Bob said to me earlier, gee, it'd be nice to have questions. We'd like your questions, please. Joining us tonight is a very special guest, Dr. Robert Talley, Dean Emeritus of the University of South Dakota Sanford School of Medicine. Dr. Talley, welcome.
Thank you.
So you didn't go to School of Medicine, South Dakota School. Where did you go undergraduate?
Undergraduate, I went to the University of Michigan.
And you grew up in Chicago?
Go Blue.
Go Blue, there you have it. And then you went to med school?
University of Chicago.
Okay, and then a residency. I happen to know some of this.
Well, my residency in general internal medicine was Yale New Haven.
So you were at Yale for residency, and then you did your fellowship in cardiology at?
Emory University.
And when you left Emory, it was I was on the tail of that. I came to Emory as a junior medical student coming from South Dakota, and they went, oh, Bob Talley. He was the cardiology fellow and teacher here, and he's going to South Dakota. I heard that and heard that and heard that when I was at Emory.
Well, you know, we did make a stop between Atlanta and South Dakota. We were 7 years in Texas, in San Antonio.
Yeah, but why did they know you were in South Dakota?
I don't know.
But they sure told me that. I heard it.
Well, one of the reasons was interesting was we were at Texas, and Texas, in their way, the government says, well, if you're going to open a medical school, it was a new school, you have to have all 4 classes.
All 4?
When you open.
Yeah.
So that weren't really sure how to do that. There turned out to be a number of U.S. students who were at Guadalajara who really wanted to graduate from a U.S. medical school. And believe it or not, a number of those students were from South Dakota.
Really?
Yes. So they came to the University of Texas. I was the teacher there. By the time I made the move to South Dakota, they were practicing in South Dakota. So it was kind of a round.
And did you come as the dean?
No, I came as the chairman of internal medicine.
And how long did you do that before you became the dean of the School of Medicine?
Good question. Let me think of the time frame here. It was about 5 years, 6 years.
And then you became the dean?
I did.
For how many years?
19.
19 years as the dean of the School of Medicine. Now, after you were the dean, Dr. Perry was the dean for 8 years, I think, and Mary Nettleman is the dean right now.
Currently, yeah.
Both of whom have been guests of this show. Well, you've been a guest on this show before. How many years ago?
I don't know that either.
10.
Was it 10?
Well, I don't know. I think it was 10. So, as dean of the School of Medicine, you've done a lot of, I mean, really, your major thing was teaching. I mean, that's what you've been.
That's what I really enjoy, yes.
And you're still doing some teaching.
I am still, somewhat to the students' regret, I am still doing some teaching.
But now, after you were dean, you were also involved with the residency program.
Right. As I finished as dean, there was a sudden need for a director of the internal medicine residency, and the national rules, you have to have 5 years of experience, and there was no person here at that time. There were some very bright people working up, but didn't have that experience. So I was the head of the residency, really almost placeholding until we could get the younger, brighter people having their 5 years of experience.
And then, and you did a lot of teaching then.
Yes.
So I also know you to be the supreme EKG teacher. I mean, part of, you're the cardiologist, and it makes sense that you would teach EKG, but you've done a lot of that, or is that just a small part of what you do?
No, it is kind of fascinating you answer that question, because I was talking to my wife and saying, I'd like to go to this seminar on teaching EKG because I'd like to get it right finally.
Yeah.
So I don't.
So when was that seminar going to?
In December of this year.
Oh, is that right?
I don't think I got it right.
Oh, I think you could give that seminar is what I'm thinking.
It's always fun, though, to have somebody else be the teacher.
Well, I love the EKG lessons that we've had at our state American College of Physicians internal medicine club meetings. That I always look forward to your EKG lessons. I hope we get more of those.
Okay.
So let's talk about our med school and so on and so forth. But let me ask you this: what really made you qualified to be the dean?
I came in internal medicine, and the truth was, the medical school, first building, first starting, probably didn't even have the credentials for the chairman of medicine that would be seen in other areas. I was young for that position. And then, of course, I was there for a period of time, really through three deans, because Dr. Wagner, the starting dean, and then Bob Quinn, and Chuck Hollerman. Actually, Chuck Hollerman preceded Bob Quinn. And your ego tells you can do it, So I've not had a problem through life with ego strength.
Is that right? You're a confident person.
So I was interested in doing it. Now, to tell the truth, I was not the first choice.
Is that right?
The first choice decided it was too risky to take this job.
Yeah. Was it a risky job, you think? It's a risky job.
Yeah, but, taking a risk, that's
part of what we do.
Right. And believing that you can achieve it.
Yeah. So if you look at your life as dean and teacher, what was an experience that you think was the best experience that made you feel, wow, this is the best?
Well, I can mention a learning experience where I finally maybe understood. Each year, I would dread going to Pier. I still don't like to even see Pier or the outline of the buildings.
Yeah, you don't like that?
No. I would dread going because I would have to go before the legislature, and they would ask, why have not you delivered a doctor to X?
This little town or whatever.
Right, in that area. And I would try to explain that. And finally, one legislator said to me, Dr. Talley, I know you can't do these things, but I want you to care. And I realized, I know how now to come to the legislature every year. I've got to care. Right.
Yeah. That's an important issue, isn't it?
It was a big learning issue for me.
So how did you show your caring?
You just tell them, the same way you can kind of inform a patient that you care about their suffering, you care about their anxiety.
I have to just say exactly what your answer is mine. There is so much in medicine that you can't help a person. You can't help them. I don't have any treatment for your failing heart. I just have nothing there. All I do have is that I care.
Yeah.
And that's almost enough sometimes. I mean, I can't tell you how important I sense that they realize when I do care how important that is to them. I mean, maybe I'm wrong, but I don't think so. So it was the same way with the legislature. They
Yep.
worked just like a patient did. So what you've told me is one of those great aha moments. What about an experience that's the worst moment for you in your experience as dean? What was the hardest time?
You are called upon as dean when students have gotten into trouble. And then it goes through various committees and various ends, and finally the recommendation sits on your desk. And I think the most upsetting issues have been when, in retrospect, I realize I made the wrong decision at that time. You're making a decision of staying in the school or not staying in the school. So those were painful decisions to make, and I think, in retrospect, I made some of those incorrectly.
Right. Okay. That's you mean you didn't always make the exact right decision?
No, but luckily it didn't hurt people too much.
Too much. Our show discussion is driven by you. Call in your questions to 1-888-376-6225 or send us an email. We need your questions. You make our show. So thanks for doing that. So, and I sense that as the leader of the medical school, you feel like you're the CEO of a corporation, and you represent, you're the head, you're the face of the School of Medicine. Did that always, was that comforting to you? Did you feel that that was the right thing?
I was very proud of it. I was quite frankly proud of it. I think an affirming type of area was, as I interacted with my colleagues, other deans nationally, you know, I ended up on the Council of Deans Executive Committee and some of those areas. So, you know, sometimes we're talking to people whose budgets were $200 million, and the School of Medicine at that time was about $12 million, if it was that. And yet, I think you still had ability to be heard, ability to have an influence, and ability to affect some of those areas.
So I know that I remember hearing from you. I mean, you spoke every year at the State Medical Association meeting about the status of the School of Medicine. And I know we were, as far as amount of money for making it work, we did it on the thinnest shoestring of any school of medicine. And yet, where do you think we are as far as quality?
First off, I think our students are quality, so we're working with a
really good group.
A good group, and that may be the reason that we're successful. And we start with good people.
All right. I mean, that's a broad scope, but I mean that's a broad brush. Well, we've got really good students. Do you really mean that? And what can you say to prove that point?
Okay, our students enter, and on some national testing, they may be under the average medical student.
When they enter?
When they enter. When they graduate, they're above the average U.S. medical student. So I take pride that the school did that, and I also take pride in the students that they are willing to do that work and achieve that level.
And so you've got numbers to prove it.
Yeah.
They're a hard-working group.
Yeah.
And who's responsible for that?
Well, I think their parents.
Yeah, it probably is true, isn't it? That good parenting.
No, South Dakota, I think, has a strong work ethic. I don't think people in South Dakota grow up believing they don't have to do that.
We have the work ethic. It's important. We're going to go to this. Tom Daschle served us well for many years as one of our senators in Washington. And in that capacity, he championed several positive changes in our healthcare system. He's some powerful insights into the status of the Affordable Care Act, or Obamacare.
I think that we have a lot. We've done reasonably well on access. We still have over 10 million people to go if we're going to have the universal coverage. That's the stated goal of the ACA. But we have enormous challenges both on quality and cost. You correctly state how much it costs per capita. That's 100% more. The second most expensive country is Switzerland, and they spend about $6,500 a year. So we're well over the second most expensive country in the world. I've always looked at healthcare, and I think we've talked about this before, as taking the shape of a pyramid. At the base of the pyramid, you have primary care, the cheapest and in some ways by far the most accessible and effective care. Cuba makes a whole case for exclusive primary care. But as you go up the pyramid, you become more and more sophisticated, expensive, and technical, until at the very top of the pyramid, you have heart transplants and technical applications to health. Every society starts at the base of the pyramid, and they work their way up until the money runs out. In the United States, we start at the top of the pyramid, and we work our way down until the money runs out. So our care is a lot more expensive because we use the most expensive kinds of care in delivering our system. That's only one of the reasons. We also have a fee-for-service system that rewards volume. The more we spend, the more volume we get, technically in the name of getting better care, but more volume often doesn't equate to better care. That's a second issue. We have very little transparency. Healthcare is the only sector of the economy where at the time of purchase, we don't know what it's going to cost or who's going to pay. And so you have all these issues. We don't put the emphasis on quality and value. And as we're talking about value, we don't have good quality measurements today. Our measurements are too opaque. The national, there are several different entities that are designated with the responsibility. We have over 1,350 quality measurements in use today, and you can't possibly figure out a way to maximize quality with that many different ways to measure it.
That was a great time with Tom Daschle I had a couple weeks ago, and we'll have a show with him, a full show with him, I'm hoping, in the winter. He is the guru in Washington, I mean, on this whole healthcare policy stuff. And he made a number of comments there, Bob. Anything that bounced off you in a way that you'd like to respond?
Well, I kind of agree that we don't know how to measure quality, and we've come off on these pieces of what you do, and the science moves so fast that a lot of these pieces are meaningless, and they were meaningless to start with as far as the patient was concerned.
Right.
And one in cardiology, you're supposed to do a study to find out whether this heart failure is associated with good systolic function of the heart or not so good. It doesn't make any difference to the patient. Doesn't make any difference to what you find. We don't, we don't know how to treat them.
Yeah.
So it kind of, drives you a little crazy on that issue. But one of my heroes in medicine is Berwick. And,
right.
And I think
the safety guru.
The safety, really the quality, yes, quality and safety guru.
Yeah.
And if I understand his message, and I had to phrase it in a word, is the system does exactly what it's designed to do. So if it's causing trouble, you don't kind of penalize the guy at the end of that whole system. You go back and say, we got to fix the system.
Right. So, I mean, are you sensing that the ACA has started some things that are good, but not necessarily all good things?
Well,
this quality.
I am a socialist.
Are you?
As far as medicine funding is concerned, I think we must have a single payer if we're ever going to control anything. So if this moved us a little closer to that, then it's a good deal.
So the question is going to be, you predict then that that we're going to come into a single payer system?
Boy, I did not buy gold when it was $35 an ounce.
Yeah.
So my predictive ability may not be so hot in those areas. And maybe it's just a hope. But if we really say we want to get control and we want to put our resources where it will increase the greatest health, I think we've got to have a single payer to direct those payments.
I will say, and you know, setting the single payer system aside question though, looking at quality, I hardly believe there's a way that you can measure quality by these tiny little issues, as Dashiell had pointed out, and as you pointed out, requiring that you do a heart failure echocardiogram on anybody who has the echo has the diagnosis of congestive heart failure. Well, you find yourself the tail wagging the dog. Well, if you want if you want to do the echo, okay, well, we'll call it heart failure. I'm not knowing. I'm doing the echo to trying to find out if there is heart failure. So there's a lot of problems with quality, I think. The quality, the issue about access, what do you think about access of health care with the ACA, Obamacare?
I'm just going to have to kind of say I don't know, because I don't know the statistics. I don't know what's actually happening in people seeking that care. So I'm just not sure. Generally, insured people get more care than uninsured people. We now have more insured people, so I would hope that it does follow that we've got better access.
My sense, however, is that I have a good friend, a smart person, has a lower paying job, has gone without insurance because couldn't afford it. Now can jump on the bandwagon and do the Obamacare and get insurance. Got insurance, has not used it, 6 months into it, and they are going to triple the cost of her insurance. And it just makes me sick, because that person can't afford it and they'll probably dump it. They'll just go without it and take a chance at the penalty. I mean, it's just the way it is. The people who are poorer or who don't have as much access to finances are just not going to gain a lot here, I'm afraid. So I'm frustrated as well. But it's a valiant effort to get, and many more people who were dumped because they had kidney disease or they had some heart failure, they couldn't get insurance to cover. Now they can, and that's a good thing.
And one would hope that nationally we can get our focus not on yes, no, but how do we make it better? You know, how do we improve upon the problems, rather than saying, okay, we're going to get rid of it tomorrow,
right?
Which we're not going to do.
No.
So
how do we make it better?
Right. I would hope our national political approach would be, we're going to try to make it better. And let's argue about how to make it better.
Right. Now, let's talk about making it better. You've been in medicine a long time, even longer than I have. And so that's a long time. So you've seen a lot of changes.
Mm-hmm.
So what would be some of the major changes that you have seen?
You know, the major change in terms of technology would be imaging. When I was in training, we had the X-ray, and that was really our total imaging area.
Chest X-ray, bone X-ray,
yeah,
that's it.
That's it. And I do remember that as a cardiac fellow, they had this echo machine that they actually used to see if the brain was in the midline. That was the only use of it. And having people, we're playing around, showing it on the chest, saying, we can actually see things moving. Of course, we didn't know what they were moving.
Yeah.
And then, so the aspect of actually being able to see those valves in that heart, I can remember that. That was terribly exciting time to do that. And then, my understanding is that when the CT scan came in, and I think the head was kind of the first area, that people came running down the hall waving the thing saying, this is worth a room full of neurologists.
I remember when it happened. It was an EMI scan, electronic music incorporated, and it was the Beatles from England who financed and paid for the CAT scan, and then it moved and evolved.
Wow.
Yeah, that was at Emory. I was at Emory under a neurologist, Dr. Keller at the time, and he said, "I'll always have a job." He didn't.
Well, he was right there.
He was right. We have a caller from a 52-year-old woman from South Dakota. Is the Affordable Care Act going to increase the number of people who have health insurance? And we kind of answered that already. It will increase. It has increased. The question is, will it take care of all of them? And there, I'm afraid it may not. We'll see. 43-year-old man from Deadwood. I mean, did you have any other response?
No, I don't.
43-year-old man from Deadwood. Has the USD Sanford School of Medicine discussed developing a bridge program to train physician assistants to medical doctors?
You know, I think that's a great question. I'm going to have to say that I'm pretty withdrawn from administration.
Yes.
So for all I know, it could be discussed. But I think it's a great question, being that we have noticed forever, if we have a PA enter the medical school, they do superb in the clinical areas.
Yeah.
So I think it would be a great idea and, you know, a proper suggestion. But to really answer his question, I don't know whether that's under discussion.
That's a good question. Or how about nurse practitioners? That's the other one.
Well,
nurse
I would.
practitioners and PAs.
Yes,
all those.
I realize that sensitivity not to be called one and the other, but I would think both should be included in that.
In that consideration. 87-year-old woman from Sioux Falls to Dr. Talley. What was your typical day like as a cardiologist? And also, what exactly is atrial fib? So there's two questions.
Okay. My typical day, I was always very involved with the medical school. So even though I was the first cardiologist in Sioux Falls, my major job was with the medical school and the teaching program and the other things. So I think my day may not be what a typical cardiologist day was. But at that time, other people were doing hearts. They weren't cardiologists, but obviously people were getting their hearts taken care of. And it was a learning issue to me how quickly everything turned to the specialist. Even though the generalist had been handling all those areas, all of a sudden, it had to be seen by the specialist. So when I was doing a lot of cardiology, I was working mostly about 4 to 9. Those were my hours, and I was mostly in the hospital and working with consults and working with patients in that area. Not a typical cardiologist, because my major job was with the medical school.
As a general internist who takes care of a lot of cardiology patients, I would say this, that there's some things that you really need the cardiologist involved. I mean, I used to put in pacemakers. Now we send them to the cardiologist to do, which makes me happy, because you got to be doing it a lot to make it of value. But there are times when the person is going, do I need to see a specialist? That's an automatic for me. I just send them right away.
Do you?
When the patient wants that,
well,
then they come back to me.
I thought they were asking you.
Yeah, and the answer is, well, I'll tell you what. If they ask me in a way of, do I really need to see a cardiologist? My question is, that's a little red flag. Maybe they need to see the cardiologist. And sometimes what happens is they come back from the cardiologist and they go, I'm happy.
Okay. I need to answer the second part of this question.
Okay, answer the second part.
What exactly is atrial fibrillation? And I guess we're going to draw on, I'm going to draw on this.
Yeah.
Okay, atrial fibrillation, the normal heartbeat is stimulated by an area up in the atrium.
Right.
And the electrical energy, like running down a telephone line, electric line, goes through the atrium and then into the ventricles, the major pumping chambers.
So where does it start?
It starts really, the start is right about there and spreads through the atrium on a number of tracks, both sides, ends up going through an AV node, which probably is right about there, and then spreads into this conduction system, electrical system within the ventricles. So that's the normal beat.
Right.
Atrial fibrillation is when the atria, kind of the holding chambers up here that are holding blood before it goes into the major pumping chambers, instead of having that synchronized contraction, begins to fibrillate. It looks very much like if you took Jell-O and waved the thing. You would see all the different waveforms. So instead of a single waveform coming down, there are literally hundreds of waveforms coming down to that kind of...
That AV node.
Right, which is kind of the narrow junction between getting from the atrium to the ventricle. I got to go through that way.
Right.
And luckily, the atrium can't take 400 beats per minute, but they come through just like if you had a terrified group of people trying to go through a single door. They would clog up, one would pop out, they would pop out very irregularly. So the ventricles are seeing these stimulus and they're beating very irregularly.
And if you have a normal heart otherwise, the rate goes up to 150 or so.
Right. A young person, that rate really goes up fast, so the rate has to be controlled. Some people with atrial fibrillation don't have to be controlled, usually elderly, because they're not going that fast anyway.
So, and we anticoagulate them as a rule.
Yes, in order to, because clots can form in the atrium when they're fibrillating, not beating. And these clots, particularly on the left side here, I should put the clot, comes out of that heart and unfortunately ends up in the brain. That will be a stroke.
Yeah.
So the anticoagulation is protective.
So there's a variety of different anticoagulation methods. Do you have any preference?
I'm an old-fashioned guy, and basically I know warfarin. I've used it for years. If the patient is relatively easily controlled, which I think the majority are, I haven't switched to the newer anticoagulants.
Right.
Now, the truth is the data seems to be clear that they are effective and maybe a little safer even. And so I may have to amend that thought as we get more and more information, but we're talking long-term treatment. You hate to kind of, I don't like to introduce a drug to my patient who they've got to take for the rest of their life when we have 1 year of experience with that drug or something like that.
And it's 4 times as expensive, even with the monitoring, than warfarin. And you know, of the drugs that are the most dangerous, this group is probably our most dangerous medications.
Yeah.
And there's only one drug that I know of that we really can monitor whether they're taking it, whether it's working, and that's that old warfarin. So I'm with you. I don't know that I'm going to always be a warfarin man, but at this point, I use the other drugs only on a certain special situation. Well, we're going to go on with this. Work on advantages in medicine is going on all over the world, from large research facilities to small colleges. Sometimes that work is recognized by none other than the Nobel Organization. What do you see as the future in the drugs that you're probably on the verge of developing or part of the development?
What we're trying to do is to take advantage of what we now know from these protein structures to see if we can make drugs that are more effective with fewer side effects.
More targeted.
More targeted, yes. And I think that we're not close to having anything in the clinic, but we are beginning to at least develop the methods and approaches that we hope will be used in the future and make drug discovery both perhaps less expensive, more efficient, and then hopefully the drugs will be more selective and with fewer side effects. It's a hope. It's not there's no promise, but that's what we're working towards.
So, receiving the Nobel Prize, I mean, when you got that phone call, I imagine in the middle of the night, as they say, from those Swedes, you know, I bet that was a great moment. Tell us a bit about that.
Yeah, that was a moment I'll never forget. Well, the phone call came at 2:30 in the morning, and we just let it ring and didn't answer it because, who's going to answer a phone call at 2:30 in the morning? But they called back about 3 minutes later, and we figured we'd have to answer it. And it was the secretary for the Nobel Committee on Chemistry, and then each of the committee members gets on and congratulates you. And I don't think I could talk. I think I was really choked up. And then within about a half hour, the phone starts ringing nonstop. And Stanford, the press group at Stanford comes to the house and helps you field interviews that you get from all over the world. And it's just a crazy, crazy morning.
That's, I'm sure, feels good, and it's a reward, and Stanford feels good about it, and you've got a job that's a little more solid, and your lab has some financial support. Is there a downside?
Yes. It's clearly the benefits outweigh the downside, but it's a very disruptive experience because you get, I mean, I'm not used to having a lot of attention and like it that way. You immediately get more emails than you can deal with, and I still haven't been able to keep up with emails. You get asked to go a lot of places, give talks. You're traveling, unless you learn to say no, the travel schedule becomes really crazy.
And then you're stuck having to do interviews with small town doctors from Brookings, South Dakota.
Yes, so I couldn't say no to Brookings, South Dakota.
Well, that's great. And the reason is, you're from Little Falls.
I'm from small town, and I went to a small university, and I would have been really happy if someone had come to UMD and given a talk.
That was such a pleasure to meet a prize winner like that, a Nobel Prize winner, and he was such a regular guy from a small town. It was fun. Research is what he does. I mean, he's an MD, but he loves the lab. I mean, he's into all of this. How much research goes on at the School of Medicine? That's changed a lot since you came.
It has changed a lot, and I think that Dr. Nettleman really is spearheading a drive to move the school more into research and different areas of research. I think the University of South Dakota, from an outside view, does not do enough research, I would think, judging a medical school. Our basic scientists do quite well, and they're quite competitive. The number of NIH grants and usually the area you judge the competitiveness is NIH.
And the basic sciences are those people who are PhDs teaching
PhDs, physiologists, and mostly biochemists nowadays, or molecular biologists, probably even better. We haven't developed, I think, the interface between then a basic science discovery and translating that into the treatment of patients. And that takes a number of physicians interested in practice but interested in research to kind of drive those transitions. And I think we have not developed that to the level that we need to really move South Dakota, not just the School of Medicine, but any of the universities forward in that type of research.
But now the University of South Dakota Sanford School of Medicine has a mission statement, does it not?
Yes, it does.
And it's different than what probably Harvard's research mission statement. I'm sensing that there's a difference. Why don't you explain that?
Well, I think the key on the South Dakota school mission is to educate medical students to serve in South Dakota, and primarily to educate primary care
doctors,
family medicine, general internal medicine, general pediatrics, those type of physicians for South Dakota. That's certainly at the top. But if you want to read down further in the area, there'll be an area to support advancement of science. Right. So you have to say, well, we've
got to do all that.
You got to do it all, right?
Well, let's go. We have a question, a 66-year-old man from Sioux Falls. Do you feel that today's medical students have chosen to go into medicine to make money? That's a great question. I mean, have they changed? Have the med students that are going into it now different than the med students when you started? And is it more money-oriented?
You know, I don't think so. I think the students that I meet have the same ideals and wishes that we all had. I think it's a very more complicated world than when I went to medical school. And I think in the way we define excellence or becomes defined in the area, it has become defined that if you're really a top student, then you ought to go into the highest paying specialty possible, because after all, you're the top student.
Right.
And I think that's
bad.
not the way we ought to be going. But some of that was, I can remember talking to a advisor to the medical school and passionately for the medical school back in the days when there was some question whether it would continue from Rapid City. And, you know, knowing our mission, and yet the person said, well, why don't you get that cardiac surgeon? He lives on the big mansion at the top of the hill, and that's how you advertise your medical school.
Yeah.
And you think, uh-oh, this is a person really involved in the medical school and really there. But that, you know, you'd like to take the person working in that clinic full of general patients.
The people who do primary care are probably the poorest paid. I mean, they're not paid poorly. They're paid very well, thank you. But on the lowest rung as far as payment goes in medicine. And if you were looking for more power and more control and more, you'd think you wouldn't be practicing in South Dakota or even in a smaller town.
Turns out, though, that it must be nice to practice in South Dakota. An awful lot of our students who have to go elsewhere to train in some of those specialties end up coming back here to practice. Now, some because they want to be near their family, and their family is aging.
Yeah.
But a lot because they'll say, you know, it's comfortable to practice in South Dakota.
Yeah, let's look at, we have some statistics about the School of Medicine, and it's in the printout before us, and
I think it's saying where our graduates are practicing.
Yes, and their practice,
and the numbers are by some of them.
So what it really does show is that our alumni are from all over the state and that we're practicing all over the state. I mean, the School of Medicine does a wonderful job. 41% stay in the state. And that was similar to what it was when you were the dean.
Yeah, that's not, and you know, sometimes you say, well, that's only half, but those are pretty good.
Competing, you went national. You went nationally. You were in the national organizations of deans of schools of medicine. That's wonderfully well represented, isn't it?
It is well represented, and the percentage that go into primary care, even though we've kind of lamented that not enough do here, is quite a bit higher than most other schools.
All right. We've got a 40-year-old man from Beersford. Could you explain the main differences between the Affordable Care Act and other forms of health care? Do you feel that the Medicare and Medicaid programs are effective? How does our national health care model compare to Canada's? And from hearing with the ACA, more insurers leads to lower prices through competition. How can we get more insurers interested in South Dakota? So let's just, you want to take them quickly, one by one, explain the main differences between the Affordable Care Act and other forms.
It is an insurance act.
Right, that's right. It's kept private enterprise insurance alive. You know, Obama could have gone with the insurance industry or single payer, went with the private the insurance industry.
It has government support of some of the issues, and it has demands of how you can or cannot select your patient, your purchaser of the insurance.
Right. In other words, the insurance has to take all takers.
Yeah.
Do you feel the Medicare and Medicaid programs are effective?
Well, I hope so. I'm on Medicare.
Are you? Do you know, Medicaid is much poorer paid.
Yeah.
do you ever sense that there are physicians in the state of South Dakota not taking Medicaid patients because they're paid poor to take care of them?
I honestly don't know the answer to that. My world is Medicaid is much younger population than generally what I see in terms of heart.
And you know what my answer to, as far as I understand it, there is very few in this state who don't take Medicaid. They take it and they care for these people, even though you're going to get reimbursed less. And I mean, that's just the way it is. How does our national health care compare to Canada's? What do you?
Well, I was going to say we have to understand that Canada's is by province rather than a really single system.
So each province is different.
Change a little bit. But then I was thinking that we don't have a national health care model, so I'm not sure how I can contrast a non-model to at least some models.
Yeah. And so would you say you think they do better in Canada's half the price?
You know, it just seems that Canada has made some decisions that make so much sense. For example, you know, and again, I'm going to reflect back on medical school world, which has kind of been my life. But if you teach in a medical school in Canada, you're paid to teach, period. You're not a practitioner who has to run in on your time and come in and do this thing, to teach this thing. You're not employed by the university in order to earn big money in the clinic. Yeah. You're there to teach. Amazing model.
You wish that had been more the case.
It has to be better to do that. And, you know, they control, and governments will make mistakes in too little or too many, you know, when they try to control the areas. But when they increase the numbers, they increase the number of residencies, right along with the number of medical students. And when British Columbia doubled its medical school size, they doubled the number of available residencies.
And we're in the United States, there are not enough residencies to take all of the med students.
And you know, we're not connected. There's not planning connection between the two things.
And then the hearing, more insurers lead to lower prices. Why can't we get more insurers so you can find a competition thing? You have a good answer to that?
Well, yeah, I think the answer is follow the buck. It must not be for their benefit to making money.
Well, and I also think that there's some rules about that too as well. So, and now, for the winner of tonight's Prairie Doc quiz question, choose the best answer. What is the reasons to like the electronic medical record requirement? Availability of records enhances the patient's story, increases time with the patient. The answer is it doesn't enhance the patient's story and it doesn't increase time with the patient, but it does have access. The answer is A. It's helping to make medical records accessible. It was Mary Jane Moser who correctly answered our question. Thank you, Mary, for your answer. The book will be in the mail soon. We'll be right back after this.
Sorry. Flu.
You're not you when you have the flu. Get vaccinated, because stopping the flu starts with you.
This ancient wisdom rings so true. You only teach by example. We all have mentors in our lives, people who serve as examples, those whose patterns of living teach us how to face challenges. Of course, most of us start out with our parents as mentors and then look to other relatives, teachers, partners, and heroes in stories worth imitating. Even before my medical training, I watched our family physician, Dr. Bob Bell from De Smet. I remember how his interests outside of medicine were very broad, including hunting and fishing, water skiing, sailing, playing cards, singing in the choir, enjoying art, and the list goes on. Dr. Bell and his wife Phyllis gave me the sense of how a superb physician family can enjoy and savor every moment of life. I watched Dr. Carl Wegner, a pathologist lecturer and the first dean of our South Dakota Medical School, whose method of teaching was with empathy. I remember how he made every one of his students feel like he was speaking directly to him or her. Dr. Wegner gave me a sense of how a superb physician values the other guy. I watched Dr. Joe Hardison, an internist at the VA hospital in Decatur, Georgia, whose diagnostic acumen and skills were famous among residents. I remember how he cleverly examined and listened to subtle clues to make the diagnosis. Dr. Hardison gave me a sense of how a superb physician uses her or his senses and brain to make a diagnosis. I watched Dr. Keller, a cancer specialist at Emory Hospital in Atlanta, whose caring way remarkably helped cancer patients deal and cope with very ominous conditions. I remember how he confidently listened and spoke with consoling words and eyes to those with widely spread cancer. Dr. Keller gave me a sense of how a superb physician with compassion for suffering patients gives relief and exemplifies medical ethics in action. And I am still watching Dr. Bob Talley, a cardiologist and former dean of USD's Sanford School of Medicine, whose concern for students and residents elevated our medical school into one of the highest levels of training in this country. A specific example is how he helped mold a new method of integration and integrated training in South Dakota, about which Harvard has copied, and into which the rest of the country is evolving. Dr. Talley gives me a sense of how a superb physician who concentrates with all his soul on helping young physicians learn can result in repercussions of caring provided by his students for countless numbers of people throughout the world. We only learn from and teach by example. We have a man from Mission who said, do the doctors have any idea how to keep physicians practicing in South Dakota reservations? Do you have any answer to that, Bob? 15 seconds.
Okay. The doctors have families. They've got to have a way to educate their children if they're going to stay there. And secondly, they've got to have health care themselves. Non-Indian on the reservation, even though I'm the physician, I've got to travel outside of it.
All right.
I won't exist long in that situation.
A heartfelt thank you to our special guest, Dr. Robert Talley, Dean Emeritus of the University of South Dakota Sanford School of Medicine. And thank you at home as well. We generally appreciate your participation in our discussion. A correction for something we said last week's essay about the importance of the meningitis vaccine inferred a lack of immunization of the young man who acquired meningitis. He indeed was immunized and sadly still acquired the disease. We sincerely apologize to the family and viewers for any confusion this may have caused. And we've had our first confirmed cases of the flu reported here in South Dakota. Don't delay, get your flu vaccine now. Reduce your chances of catching the flu bug, who, by the way, is going to be here next week. We'll see. Take care and stay healthy out there, people.
It is that season again. The flu bug is everywhere. Time to roll up your sleeves and beat the flu bug at its own game. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Swiftel Communications,
and Vance Thompson Vision.
Closed captioning for On Call with the Prairie Doctor is provided by
Avera,
Brookings Health System,
and Fishback Financial Corporation.